Welcome to Working with Persistent Pain, an exploration of strategies used to stay productive at work. Thank you so much for joining us. My name is Yusra Benjenoun, Administrative Coordinator and Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC government, as well as donations and memberships to WWDPI. We thank our program partners, Pain BC, Sport Chronic Pain Network, Canadian Council on Rehabilitation and Work, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week along with the slides. You will be emailed the direct links for all of these items when they're available. As I mentioned, my name is Yusra and I'll be moderating the webinar and Q&A session. Our presenters today are Dr. Jody Oakman and Dr. Tia Laloka. Dr. Jody Oakman is an associate professor at the Center of Ergonomics and Human Factors at La Trobe University in Australia. She's the head of Department for Public Health. Her background is a mix of industry and academia. Jody has worked extensively in industry across a range of sectors including health, manufacturing, and logistics. Her PhD is focused on the aging workforce and the impact of organizations on their employees' retirement intentions. Her research is currently focused on the impact of the psychosocial work environment on musculoskeletal disorders and strategies to improve risk management in workplaces. She has several higher degree students researching in this area. Dr. Tia Laloka, Adjunct Professor, Academy Research Fellows, is a senior researcher at the Finnish Institute of Occupational Health at the University of Helsinki in Finland. She's also an affiliate of the University of Sydney, Australia, and is an associate at the Karolinska Institute in Sweden. She has over 200 scientific publications, of which 150 are peer-reviewed international articles. More than 100 studies have been done among employed population, addressing inequalities in health, working conditions, as well as trends in sickness absence and transition into disability retirement. She is currently working on a project focused on pain, mental health, and work participation. And now I'll hand it over to you, Tia.
Thank you, Yusra, and good afternoon. It's actually good morning in Sydney, and I'm Tia, currently based at Woolcock Institute. So you see the topic of my part of this webinar, and in about halfway we'll be changing turns and Jody will continue. So I will be basically showing evidence, scientific evidence about pain and exit out of employment. And the picture you see here was taken a couple of days before me flying here to Sydney. So I'm from Helsinki and it was actually -20. And as you can't see me, I'm showing a picture here. This is how I look when I'm at home and when it's -20. And actually, this is last weekend here, so a bit of a difference, some 60 degrees, family in Adelaide. But you don't need to be too jealous. It was really rainy this morning in Sydney when I came to the office. So I'd like to begin with a few of sort of take-home messages that we'll be going through today. So the overall key message is that pain is a serious public health and societal challenge. And this is based on scientific evidence, which we are going to go through some points. And the reason I'm saying is that pain often leads to short or long-term work disability and even early permanent exit out of paid employment. However, this does not need to be so. There are ways and evidence to show that, for example, work accommodations, modifications in working conditions may help, and also lifestyle changes could make a difference. For example, smoking cessation, increasing leisure time physical activity, maintaining healthy body weight. And I'll cover some of these points, and Jody will tell you more. So, to begin with this sort of highlights the idea that I'm going to go through and see pain as a life course question, that pain is really common, and it's not only during working age, but already common among children and in adolescence. And while it's common, it also tends to be persistent and recurrent. And during this talk, you will see more about this. And before the actual results, I made this really simple framework showing sort of how these studies have been done and what is the idea behind studying pain and exit from paid employment. So there are factors already in childhood, both risk factors of pain, but pain in childhood, and this pain may be linked to pain among working age people, but also pain during midlife might have its roots in childhood, and that's why it's important to consider pain as early as possible and detect and tackle the risk factors as early as possible before pain becomes chronic, for example. And most studies actually have focused only on aging people, aging employees and exit, but there's much less evidence about young people and people during their early working lives. So we'll soon look at that. And here I also listed a few of these factors that are key determinants of pain during life course from childhood to working age and older life. And most evidence is related to different lifestyle factors and work-related factors, and I mention these here because they are potentially modifiable. So that's why it's important to consider evidence related to these if we want to prevent pain. So these are some of these factors that we may consider modifiable, but that are risk factors of pain. And most commonly, studies have examined physical working conditions. The first picture here, and obesity, importance of physical activity and smoking, and particularly low back pain, which is the really common form of pain. So we look at these, and there's a lot of evidence that women report pain more than men. Older people report low back disorders more than younger people, although local pain is common among young people as well. But there are really few studies that have actually examined this social mobility. And this is a study we did a few years ago. This study focused on life course socioeconomic position, meaning that whether your parents had high or low education and whether these children then themselves acquired high or low education. So upward mobility means that the parents had low education, but the children themselves had high education. Downward means the parents had high education and the children low, and stable low position means that the education of both parents and children was low. And these are the two last ones that have shown the most strongest associations with the risk of low back pain, even decades later. So this highlights the importance of social position and life course social position to low back pain. And then an example of the importance of physical work. So in this study, we actually were able to measure physical heaviness of work during a long follow-up from the start of working life to midlife. So it was measured 3 times, and then we followed up low back and other musculoskeletal disorders using register data, meaning primary healthcare visits. And we studied different outcomes, but I only show here one of them, upper extremity diseases, which showed the strongest associations. But the most consistent ones were for spine disorders, actually. But in here, those who had physical work exposures throughout their working life had most upper extremity diseases over the follow-up after measurement of this physical heaviness of work. So this was a really long follow-up, 28 years altogether. Then I show one example using Swedish data. And in this study, we examined incident low back pain, meaning that these people had no pain when they reported these risk factors of pain. We studied which of these affected the risk of back pain in future. So this shows that every time the column and the confidence intervals here are above 1, it's statistically significant. So it shows that, again, here, as in Finland and other countries, also in Sweden, physical work is the really consistent predictor of incident low back pain, and also sleep problems and overweight or obesity. So then to the exit part, I show this because in these studies, when we examine exit, we need to control and take into account all these social factors, work-related factors, and lifestyle. They also contribute to exit, so they are the background here. And the main results I'm showing today are related to multi-site pain and recurrent pain, which means pain that's repeated several times. And this here, a new study, it actually should be published anytime, so it was recently accepted. And this is, as far as we are aware, the first study that compared within individual and between individual associations when studying pain and sickness absence. So there's a lot of previous evidence focusing on how pain leads to sickness absence, but all of those studies have compared people who don't report pain to those who report pain. But this may lead to really overestimated associations, and it is because those studies don't take into account stable factors that are related to the individual. And this means that if I feel pain and you feel pain, it's likely very different. And these studies that have been done earlier have not taken that into account. So in this study, we have both these between and within individual associations. And you can see here that all of those associations where we looked at between individual association, comparing all those who report and don't report pain, the associations are stronger than these within individual estimates, which consider these covariates that are stable over time and control sort of the associations within this person reporting pain. But anyway, although the associations are weaker, as previously reported, they still are significant, meaning that pain contributes to future sickness absence, even doing it this new way. And these associations are shown both for short-term and long-term effects. And short-term means within 1 year or within the year after reporting pain, and even with a 2-year period after reporting pain. And in this slide, we also show how this association between pain and sickness absence compares to other factors known to affect sickness absence, like long-standing illness or mental disorders. So they are strong contributors to sickness absence, but just to show how the estimates are. And this is here the green part showing acute pain and chronic pain. So as could be expected, the associations are stronger when looking at chronic pain. And again, stronger if looking at pain that's reported to be in one body location or 2 or more. So multi-site pain is the strongest predictor of future sickness absence. So then this is a study we are just doing. It's not published, but ongoing. And we are doing this with Jody, the next speaker. And here in this study, we wanted to have a more detailed look into this, that whether you have pain only in one body site or in several sites, this is the multi-site pain, or whether it was reported just once or repeated over the follow-up. And again here, as might be expected, pain that is recurrent, reported over the follow-up, and pain that's in several body locations, it's the strongest predictor of long-term future sickness absence. And we also looked at whether such pain predicts permanent exit from paid employment due to musculoskeletal diseases. So this is disability pension diagnosed, and the same result, but these associations are really strong. So confirming that self-reported pain over the follow-up leads to health-related exit. And this is another study where we looked at that, but using British data. This is a Whitehall 2 study, and again, a really long follow-up, 28 years, and this was published last year. And in this study, we looked at both health-related exit, which could be sickness, absence, or disability pension, and then exit due to other reasons than health, and exit due to unemployment or other reasons. And here are the numbers, how many exits happened during the long follow-up for these reasons. So mostly the exits were non-health related. This is because these people retired due to old age. But anyway, health-related exits were really common as well. And they were the only ones that had associations with pain. So recurrent pain repeated several times over a 10-year period was the strongest predictor of health-related exit, which is this one. So as you can see, this column is really much higher than these other ones. And this first one is showing combined effects of all of these. So it reflects these health-related exits, and these other types of exit, they had no relation to pain. And this is how it looks when, and this figure here highlights the importance of recurrent pain. So those who had no pain during 10-year time, or those who reported pain just once, did not differ so much. So the blue and green lines, but it's clear that having recurrent pain over 10-year time was the strongest predictor of health-related exit. So for those people during this 20-year time from wave 4 to wave 11, that was the final follow-up point after 20 years of follow-up. So those with several pain reports earlier, almost like 30% of them had exited paid employment due to health reasons. So after these results, one might ask, can something be done? And we have actually an example from Finland, and there hasn't been really clear guidelines how to prescribe sickness absence, and there actually are really major differences in how physicians prescribe sickness absence for same diagnosis. There was a recent PhD about this, showing even 8 times higher numbers of sick leave days for same conditions, but prescribed by different physicians. So there was this sort of experiment within one employer, largest employer in Finland, 40,000 employees within the city of Helsinki, and they introduced few guidelines how to prescribe sick leave for these conditions listed here. They are all musculoskeletal conditions, and there are detailed guidelines for physicians, occupational health physicians, how to prescribe sick leave for these conditions. And after these guidelines were introduced, this is what happened. So number of sick leave days for all of these conditions really significantly dropped. You can see, like for back pain 42%, shoulder pain 46%, for elbow pain 73%, and so on. So the actual number reduced was this high. So meaning that, as I said, there are 40,000 employees working for the city of Helsinki, and these guidelines only for these few specific conditions resulted in 20,000 more days with work ability. So this much less sick leave days. And on average, it's estimated for the city of Helsinki, one sick leave day costs about 250 euros. So this means that during this time, city of Helsinki saved this huge amount of money, but also obviously we talk about better workability, not only about money. And although pain tends to lead to sickness absence, one of the reasons why those guidelines were introduced is that actually there's no scientific evidence that for most people work would be harmful, or it doesn't slow down recovery for most people, and so on. quite on the contrary. And actually many people with pain have good workability. And this is blank now, just because I'm giving you a few moments to think how high you think the columns are. So how many people who have multi-site pain, pain in several locations, actually themselves say that they feel they have good workability for men, women, and age groups, young and older employees. So this is how it looks. So actually quite large numbers, even with multi-site pain, feel they have good workability. And then this is another study looking at what then might predict having low sickness absence even with multi-site pain, and what are the potential modifiable predictors of sickness absence. And this was a long follow-up, a study that was representative of all Finnish working age adults. And these are the factors that were found. So there are several work-related factors and behavioral factors that were found to predict lower odds for sickness absence. And these are these physically light work and other physical exposures, and reporting no mental stress, and then having this normal body weight and sleeping well. So these factors predicted belonging to this low sickness absence trajectory over the follow-up. So as the take-home messages said, pain is a burden, but at least in Finland, and I guess in many countries, it's actually not a sufficient cause for disability pension. It might be a trigger, but it has these important modifiable predictors, and these results already among young people highlight the importance to tackle and detect these risk factors and pain as early as possible to prevent pain becoming chronic. And actually, I think Jody will cover most of these points and go into more detail about what kind of work accommodations there are and how they might make a difference, and the intervention studies, for example. And I already mentioned here that there will be questions and answers in the end. So if you have any other suggestions or anything you'd like to ask, so we will cover those after Jody's talk. Thank you.
Hello, Jody Oakman here. I'm in Melbourne, Australia. I don't have any pictures, unfortunately, and I know there's a number of Australians, but anyway, we'll have to do without pictures. So I'm going to pick up where Tia left off to talk about the issues that we can do, or we can develop in workplaces to try and accommodate people with persistent pain. Clearly, there are a large number of people that have persistent pain, and we know that work is good, or it's better to be in work than not. And so I'm going to explore what these things that workplaces can actually do. Workplaces are an important part of enabling individuals to remain at work, and so they're very much part of that process, that enabling process. A key message is that supportive employers are, of course, a key part of this to ensure the effectiveness of workplace accommodations, and I'll expand on that. And then resources for managing persistent pain are needed to target employers and to help educate them and inform them about what can be done and where to get support from. We know it's highly prevalent. This is Australian data, and nearly 7 million Australians are impacted by arthrosis or other musculoskeletal pain, and that figure is no different to other countries around the world. And Tia said that, shown us some very nice data that supports that it is more, whilst it might be more difficult for people to maintain employment with musculoskeletal conditions or persistent pain, that but that doesn't mean that they can't be at work. One of the issues, we know that it's more common in older adults, and one of the challenges we have is that we have an ageing workforce, and people will need to stay at work for longer. And this raises some interesting things for us to think about, is how we actually maintain a life across the life course, as Tia said. But if our work life is going to be longer, this will increase the exposure we have to that work environment. And so this means, I think, there's increasing pressure on us more generally, or managers or organisations more generally, to think about how those accommodations might work, and not specifically to target older workers per se, or those with musculoskeletal conditions, but to think about how accommodations might be beneficial for all workers across the different life stages. And just some data there, some figures which you'll have had time to read while I've been talking, that just shows that there is an increase in prevalence compared to younger age groups in terms of back pain, and these are large multi-country studies, the CUPID, the British study, showing that 12-month prevalence for low back pain is about double older workers compared to those in their 20s. So, taking all of these things into account, what I want to talk about is what that actually means in terms of accommodations. I just move into that thinking this is data from Kupio's study by Krauss, and there are some references at the end, but just showing the predictors of likelihood to end up on disability retirement. If you've had a serious injury in the past, then you're 2.73 times more likely than those who haven't. And even looking at just back pain, you're more likely to exit work earlier on disability than those people without back pain. So these are important things in terms of both where pain is preventable in terms of work-related, and in terms of managing those conditions that are not work-related. Now, taking an ergonomist, I am an ergonomist, view of the world, I like to think about the system of work and how those accommodations might fit within the various levels. And I'm going to talk about some studies now, which is how we've actually framed the evidence and the analysis in terms of a work system model. And we know, according to macroeconomics theory, that productivity is improved, or should be improved, when individuals are well matched to their what they can do, their work environment, and this gives a better outcome for organisations and better for individuals. And logically, people are more able to stay at work if these things are well matched. So we undertook a systematic review here at La Trobe to look at to determine what the characteristics of workplace interventions are that are most effective in assisting people with persistent musculoskeletal pain to remain productively employed. And I'll just talk about the results, but I'll refer you to the paper for further details. And what we found was, this is not atypical, that no high-level evidence for workplace interventions to assist people was identified. Now, this doesn't mean that there's no evidence. It means that doing interventions in workplaces is incredibly challenging. And when we undertake these reviews, we often, and we apply very strict criteria to the articles that are left in for the review. And workplace interventions, we have to do a whole range of things to get them to work. And those of you who are practitioners will know this, that things change rapidly, and undertaking very rigorous, well-controlled scientific experiments or studies is incredibly challenging and almost impossible. So the issue here is not that there's the issue here is about how we actually categorise studies and how studies are done in workplaces. And I could talk at length about that, but we're here to talk about accommodations. So there's a low number of participants and so limited number of studies. But what we did find was that individually focused interventions will probably reduce job loss and sick leave, but they're unlikely to reduce pain. And so that doesn't, we know that people can continue working with quite significant amounts of pain. And so in workplaces, the focus should be on job loss and sick leave. So there's some very good things we can actually do. But we also need to focus on different levels of the organisation. And I'll talk about that a bit more. But that multi-level focused interventions will probably result in decreased sick leave and provide some cost benefit. What we did find, though, was that the evidence on productivity was very limited. lots of challenges in how you measure that, and the evidence was quite poor quality. There are some things that organisations can do, and there's a body of evidence now that supports that actually doing things at multiple levels in the organisation is more effective than just doing one thing, which is somewhat contrary to how we might typically approach other sorts of scientific experiments. But in workplaces, do a lot, do it early, and do it at multiple levels. So what we then asked people with persistent pain what they wanted and what sort of resources they were looking for. And I'm just going to talk about the combination of two studies that we've undertaken here. And the first one was to look at supports, work and non-work, that people used to assist them in maintaining employment. And the second one was the sort of resources that they were looking for with non-work related back and neck pain to maintain productive employment. And how should these be communicated and provided? Where can people access them? And then what sort of strategies and resources are required to facilitate communication with employers? And I'll just present the high-level findings here, but I'll refer you at the end to where you can find more information about those particular studies. And I'll just start with a quote. These were qualitative studies, I should say. So those were interviews. We spoke to people across those two studies. We've probably spoken to about 80 people and surveyed more than those. But one of the key issues that people have with persistent pain conditions, whether it be back pain, neck pain, or any of the arthroses, is what happens if I can't work. So what does my career look like? And this crane driver here articulates it very clearly that he's the main breadwinner. There's a lot of people down at my work who will never work again because of the repetitiveness of our work. So it crosses your mind, gee, am I going to be all right? Or am I going to be the next statistics? And it's me, it's having a young family, and it's a scary prospect to get you to where you're like, I could be in trouble here because I've got nothing to fall back on. And we heard this from a number of people who felt that they were very stuck where they were in their particular jobs they couldn't see that they had skills where to move because of their condition and their skill set. And there's a real gap there in providing career advice around what needs to be done. And of course, disclosure is a really key part here, because if you don't disclose your condition, it's very hard to establish, create or develop good quality accommodations. But there are a whole set of challenges around disclosure. And what we found was that some people were quite open, open disclosure, and it was relevant and they were comfortable, they had good relationships with their employers. Some avoided disclosure because they felt they would be prejudiced against, either in progression or actually getting the job. And some, the disclosure happened incidentally because they couldn't manage a certain aspect of their job, and so they needed to disclose, or it happened accidentally. They told someone, and someone told someone else. So there's a whole range of things, but it does underpin the whole discussion around workplace accommodations. There are, of course, a number of barriers to working. These were some barriers to working productively, or barriers to putting in place workplace accommodations. You can see there that we've looked at those at different levels: organisational factors, physical work environment, and then personal limitations, which feeds into the discussion around workplace accommodations and how they need to be multi-level to be most effective. And so this starts to, when we're thinking about accommodations, of course, we can think about what some of those barriers might be. It informs how we might be able to develop more effective accommodations that are likely to be implemented and then sustainable. And of course, the sustainability part is really key. Now, enablers, these again, what we found were that the supportive employer was absolutely paramount to the effectiveness of implementing workplace accommodations, the design of the jobs, so how people could construct what they needed to do, which was strongly linked with people having some flexibility. And that didn't mean that they didn't do their work. What it meant is they could choose the order or how they did it, and that enabled them to work around what may be some of their physical limitations. What it did mean for a number of people was that they went and worked at for themselves, but it also meant that some people had constructed different working lives because the career they were in wasn't actually going to work. Job design also included how the number of hours people worked. Many people chose not to work full time. There's of course some physical work environment, being able to actually modify that. People used medication and therapy to enable their work, having access to resources to assist them in where to find different useful things was considered an enabler. And then people very strongly felt that having a positive attitude to wanting to work was really, really critical here, because some days were really quite challenging. When we looked at what people wanted in terms of resources and a piece of work we've just finished, the second study there was particularly targeted at what people wanted and where to get it from. People were very influenced by their GPs and their friends and family, and what was a very common theme across the people that we interviewed was that there's, as everyone knows, Dr. Google offers an enormous amount of information. But what people found very difficult was what was reputable and reliable, and how to make those sorts of decisions. And this is particularly difficult for people from non-English speaking backgrounds. Remember, this study was undertaken in Australia, and people found it very challenging to interpret what was quality information. So we looked at making some recommendations for Musculoskeletal Australia, who we were undertaking some of this work for. So, what we looked at was whether the resources, what resources need to be targeted at community level, organisational level, and individual level. So, taking into account that, as I said earlier, that we need to target interventions at different levels. So, logically, we need to think about the resources being at different levels, because people have different requirements. Employers are looking for things that will overlap, of course, with individuals, but there will be some differences. So at the community level, the first part of one of the recommendations was increased publicity of MSK Australia website and resources. Now, you could put in place a whole number of different organisations instead of MSK Australia, and I deliberately left that there because what people were looking for was a reliable not-for-profit or association that actually they could trust the information that it came from there. So in any country, you could put in place, an organisation that is well trusted to house different resources or information. And what they wanted, what was another very common request was actually information about jobs and what sort of jobs. What they actually asked for was physical rating of particular jobs and how jobs, what jobs were constructed of. So sort of the physical demands of jobs. So people can think about how they might design their career in future transitions. I think this is really important, particularly for some of those conditions that are actually across the life course, some of those arthroses. People need to make decisions, want to make decisions in their 20s so they can actually plan a career that they're going to be able to do. The employer, and this is a real gap, is about what employers need know about appropriate accommodations, so where either the worker can refer them or the employer can refer themselves, they're looking for information about what they can do or what constitutes appropriate accommodations. And linked with that is about how to access services for advice on workplace accommodations. So where they might go to actually seek out appropriately qualified professionals to do that at work. Also looking for short snapshot presentations on different topics about accommodations and availability supports. I think what's really important here is about reinforcing the message that lots of people, if they offer accommodations, that doesn't mean the whole workforce is going to need those. And just offering accommodations doesn't necessarily mean people are going to access them, but they're available if people actually need them. And there's a body of evidence, I've got some references there, about who takes up workplace accommodations and the rate. And it's people with chronic conditions don't always need accommodations, but having them available means that if they need them, they are there. There's individual at the workplace, and across a number of studies we've done, people have wanted to see case studies of people in managing particular employment with a range of conditions, and then exemplar employment situations. So employers who do a really good job of managing accommodations and the provision of accommodations. Also, the provision of resources to inform individuals about their rights and responsibilities in terms of disclosure. And again, this was very common across studies that we've done. Also, people wanted online resources with information on workplace supports. And this is linked to the employers, of course, but this may be where individuals want to bring someone in of their own volition to actually assist them. So they have different needs. And then career planning. I've alluded to that before because it really does underpin a number of decision points that people have in terms of accommodations. And if we're looking at really trying to promote sustainability of employment, this is a really key aspect. Giving people information about how to make decisions about suitable careers or how they might facilitate a career change, which may take a number of years because it requires retraining, but how to actually put in place some steps towards doing that and where to go for career advice. And so just an additional note for employers or people who need to negotiate with employers, there's a range of studies there undertaken over in Canada, as there'll be many people on board from Canada listening, that even though people with quite significant conditions, chronic conditions, the use of workplace accommodations has been found to be relatively low. I mean, and there's many complexities around this, having to do with disclosure, but having these practices available and due to the intermittent nature of symptoms, it means that people can use them or tap into them when they need them. Key to all of this is flexibility, and it's useful though for all employees to have flexibility to be able to better manage work-life interaction and improve sustainability of employment. So this is just to remind us that it's not only targeted at people with persistent conditions. These accommodations can be useful for all workers. There are some gaps. There are some research gaps in terms of evidence. The intervention studies are lacking, or they're limited in number, and a particular focus on what enables sustainable employment. There's some gaps on guidance around employers and the effectiveness of that guidance on the benefits of managing and supporting people with musculoskeletal pain. And there's a need for more longitudinal research to establish the cause and effect of accommodation provision. Right. And just a little note about us here at La Trobe, and these will be available on the slides, and a link. And if you're interested in finding more about us, go to there. And we also run training courses in risk management of musculoskeletal disorders, so you can register with us if you're interested. And if you want to find me, that's how you do that. And references. Thank you for listening. And now I think we're going to take some questions.
Thank you so much, Jody and Tia, for this compelling presentation. Right now, we'll start our Q&A session. So to our audience, please insert your questions in the question box whenever you're ready. Our first question today is, do you have any information on days away and work-related mental health issues, such as stress, for example?
We have studied quite a lot also mental health and work participation, and also links between pain, mental health, insomnia, and sickness absence. So there's really a lot of studies, but this time we focus the talk on pain and work participation.
I mean, a big issue, Tia, also is presenteeism. So even though people are at work, their performance with physical or mental health issues can be less than optimal.
I'm not sure if the person who asked the question would like to add anything, like what kind of things you would like to hear about. You mentioned about it, but feel free to add anything.
Yeah, for sure. We can come back to that, and we'll ask the person who asked this question to just bring some clarifications, please. So moving on to the next question. Can you elaborate more on the link between smoking and sleep deprivation and increased pain?
Okay, I think this might have been about one slide during my part, and actually we did not study the link between smoking and sleep. There are some studies showing that, yeah, for example, insomnia and smoking might have some correlation, but in that study I showed, we did not look at that, but we looked at each of these lifestyle, work-related and social factors as independent predictors of incident pain. So they both have some links, particularly sleep and pain are connected. And there's actually another study I did not show that's important, that, for example, you know, pain is really complex and causal associations are difficult to establish. And for example, for those who have poor sleep, they are more likely to also perceive pain. And I've been involved in one really large Norwegian study, more than 10,000 participants, and they did cold pressure test, meaning that they held their hands in cold water. And the more severe sleep problems you had, the shorter the time you could hold your hand in cold water. So poor sleep changes how we also perceive pain, and all these things are connected. And we have also done another study showing that those who have both pain and poor sleep are the most likely to exit work, and there's sort of a synergistic interaction, meaning that the associations, the links, it's stronger than you might expect for just adding these two together. So synergistic means that they even increase the effects if you have both of them, but they also have independent effects. Those who have sort of only pain but sleep well, or sleep poorly but don't have pain, they both have increased risk for work disability, but the risk is really much higher if you have both. And for smoking relationship to pain, it is there. It's not really strong, but it has been shown in many studies that smoking is linked to increased pain, but the effects are really much weaker than for sleep.
A great explanation, thank you. So next question is, what are the most effective strategies for accommodating mental health conditions such as depression and anxiety? And related to that, do you have any insight on where to start, how to evaluate the needs of employees facing such difficulties?
Mm.
So what do you like?
Yes, so not specifically, because that wasn't what we covered about mental health, but I think there are some general principles which apply. The big thing that underpins that is disclosure, because it's very hard to develop accommodations if you don't know what the problems are. So one of the key things is about having supervisors and managers that are able to discuss with the employees that require them what their needs are and how they can actually get that to work in a productive way that suits both parties, because it does have to work for both the employer and the employee. So it's about the conversation that needs to happen, and then it's about putting things in place and then evaluating whether they're working or not, again for both parties. And so the challenge there is about that open dialogue that's productive.
Yeah, I agree. And one thing that actually in Finland, I've been involved in some interventions, and we have tried to identify, and I had a small part, but I know something about the studies anyway, that identifying people with mental symptoms as early as possible and trying to also support return to work as early as possible. So, and also actually we have a system now that you can work half-time with, for example, having mental symptoms, same with pain, and get full day salary, for example. So we have really good coverage for all employees. They all have access to occupational health care, and so sort of working there, trying to detect symptoms as early as possible and have this good communication between occupational health and employees and the employee, all of these three.
Keeping people at work and getting them back really early, so with minimal time off, is really key there to the success. As soon as people are off work, it becomes more difficult to facilitate the return, and the outcomes are poorer.
Thank you so much. Another question was, what are your recommendations regarding disclosing disabilities and health-related issues? It's difficult for leaders to implement effective measures if they're not aware of the problem. But based on your experience, are there any risks to disclosing disabilities?
Yes, I think we've touched on some of those, and unfortunately, I think it's highly variable and depends on the employer, and there are some country differences too in how the system manages. Tia just gave a example where in Finland they have the half pay. You can work at half time but get full pay while you're rehabilitating, but that's not so in all countries. So sometimes for employees there are huge risks with disclosing, and then of course it's very difficult for the to develop the accommodations.
Another question, what do you think regarding ICD-11 and implementation of pain as a diagnosis in combination with disability changes? Do you think this will have an impact on disability pension?
I'm not able to make a meaningful response to that, because I don't. The answer is I don't know what it will do to that.
It's a good point, and I actually I'm not a medical doctor myself, so I'm an epidemiologist, and I have to look into that. Actually, I appreciate the question. They have to, yeah. I will look into that, but unfortunately, I also cannot answer now. I'm not working with ICD codes so much, and not with any patients, for example, just the data doing the studies.
We can always share any information, and we can email that to our registrants and post it online as well. Thank you so much.
Yes.
Yeah. So another question. Well, they say, "Hi, Jody. I'm currently working in a return to work rehabilitation program. We're looking to expand our education topics for individuals with injury and musculoskeletal disorders. What topics do you think would be most helpful as a healthcare provider to provide to enable individuals?"
To return to work, was that the question?
So educational topics about returning to work for individuals with musculoskeletal disorders.
Yes, it's a good question, and I think the issue is to get people back to work very quickly, as they can. But where I see the gap is about getting the employers on board so that they understand the importance of keeping people at work and the value of the accommodations, rather than the accommodations can be sometimes seen as burdensome, that they actually are facilitating both improved conditions for their people with issues, but also as part of a preventative program. So I think that's if I had to prioritise my targeting, it's about getting the supervisors on board and making sure they understand their role, the importance of their role in the system.
Perfect. Thank you so much. And maybe we'll have a couple more questions and then we can answer later on. Hi, Jody. I just went to APHIRM website. The toolkit for healthy and safety professional doesn't seem to be available. Do you know when this will go live?
I have my next meeting is about the date that it will go live. So it is very shortly it will go live. It's being redone. So it's coming. Hey, go back in another, say, 2 weeks, and I think it'll be up. But you can register for information.
Perfect. Thank you so much. So the last question is, how would you advise someone whose employer is not willing to work with them to modify or adapt their working environment?
Look, that's very difficult. I mean, find another employer is the flippant answer, but not always very easy. But that if the employer is not willing to engage, it's going to be very difficult if someone has an ongoing problem. And this is where I think it's really important for people to have a plan about what else they might be able to do and put some strategies in place, because that's very difficult.
It's true. This is an important but difficult question, but I think also it needs this collaboration, if possible, to involve an occupational health physicist and also this scientific evidence, and whether the employer wants to think short-term or long-term. They might think only short-term savings, but actually sometimes talk about money will help, like thinking that long-term they might actually save, helping the employee to maintain his or her workability during longer term than just thinking of whether they can invest to them during the next couple of weeks or so, but thinking of long-term savings and long-term opportunities to continue working and being productive at work and have good health and well-being. But there are this scientific evidence and many things that I hope, but it's true, it's not always easy.
Thank you so much for taking the time to answer these questions. We still have about 10 of them, so we'll just save that and respond later on. I would like to thank Jody and Tia. We're honored to have you today with us for this very compelling webinar. Thank you so much for sharing your valuable knowledge and various extremely useful resources and strategies to cope with pain while staying at work. We really appreciate your sharing your time with us. To our audience, we're grateful for your participation. Thank you for joining us for this webinar.